Hi, my name's Hellie Badaruddin. I'm a sophomore international relations and French major, and I did a research project on homophobia and anti-sex work discrimination in African HIV/AIDS infected nations and how that impacts their ability to fight the epidemic. So, limiting the HIV/AIDS epidemic in Africa is impossible without specific investment and attention in key populations. Those key populations are members of the LGBTQ plus community, men who have sex with men, and female sex workers. They have the highest HIV/AIDS prevalence of any other group in Africa and the world, but they receive some of the worst treatment and attention of anybody else. They're key populations in limiting the spread of HIV/AIDS and achieving the global 90-90-90 targets for HIV/AIDS. The primary barrier here is the stigma against sex work in the LGBTQ plus community. All the other problems with it pretty much stem from there. The HIV/AIDS epidemic is unequivocally rampant in Africa due to poor governmental and health structures. 1 out of every 20 adults in sub-Saharan Africa is HIV positive, and Africa has long been the continent hardest hit by the epidemic. 70% of people living with HIV worldwide are from Africa. Within the most HIV/AIDS prevalent continent on Earth, though, exist multiple vulnerable communities with especially high infection rates. As a population with a higher number of sexual partners per individuals, female sex workers have a disproportionately high HIV/AIDS prevalence, and it ranges from 24% in Ethiopia to as much as 72% in Lesotho, and 37% in sub-Saharan Africa as a whole. Lesotho is the small country on the inside of South Africa, and as you can see from this photo, the epidemic is particularly rampant in that region. The infection rates for members of the LGBTQ plus community are also abnormally high, specifically for MSM, or men who have sex with men. While considerable emphasis has been placed on HIV/AIDS testing and condom promotion among female sex workers and men who have sex with men to target the HIV epidemic, the infection rates suggest that much more attention and effort is needed. The LGBTQ plus community and sex work communities, due to a disproportionately high prevalence of cases, play a significant role in transmission and spread of HIV/AIDS. According to the Joint UN Program on HIV/AIDS, it estimates that between 40 and 50% of new HIV infections that occurred in 2016 globally were believed to have originated from these key populations, which were gay men, men who have sex with men, female sex workers, and other members of the LGBTQ plus community. Notably, these populations' role in the spread is primarily due to external sources like stigma, the illegality, and poor access to healthcare institutions. So it's really not necessarily their fault that they're spreading the disease, rather the systemic issues that have caused this. Unfortunately, according to Chia Mbako of the New York University Press, politicians have also used this political whorephobia as a way to scapegoat sex workers for HIV, which shifts emphasis from their own governmental shortcomings in HIV prevention and treatment efforts. So, for example, in Zambia, this scapegoating was so effective that it drove sex workers from the country and further developed the attitude that they were to blame for the spread of the epidemic. Though they aren't responsible for it, the LGBTQ plus community, men who have sex with men, and female sex workers play a significant role in the extension of the epidemic, which their communities tend to use this fact against them. Homophobia and transphobia and whorephobia, which is like stigma against sex workers, contribute to institutional and social stigmas against the sex worker and LGBTQ plus communities. These prejudices seep into governmental structures and policies. Legal discrimination against LGBT people in Africa is widespread. In 38 African countries, homosexuality is illegal, and sex workers face a similar legal challenge. It's criminalized in Botswana, Kenya, Namibia, and Nigeria, and there's no country in Africa where it's decriminalized and afforded the protections of other service professions. The legal discrimination and general prejudice against these key populations play out in nearly every facet of their government, from medical to educational institutions, and it further develops the social stigmas against them. These stigmas severely limit the ability of African nations to curb the HIV/AIDS epidemic, primarily due to these legal barriers, medical bias, and an overall lack of understanding about how these communities live. These populations in religious communities and nations experience the worst of these stigmas. In general, most faith-based communities, specifically Christian and Islamic, which are more popular religions in Africa, they're explicitly against both sex work and homosexuality. An increased stigma in those communities inevitably leads to more discrimination. As European colonizers developed many social service institutions, like medical and educational services, homophobia and whorephobia were deeply ingrained in the services that key populations now need the most to fight this epidemic. Consequently, the harms of that stigma are particularly prevalent in faith-based organizations, facilities, and communities. So now let's move on to why this stigma is so bad and how it impacts their ability to fight the epidemic. The stigma against sex workers and the LGBTQ plus community has real tangible impacts on African nations' abilities to fight the epidemic. The illegality of their existence and profession, among other legal barriers, discourages sex workers and members of the LGBTQ plus community from getting tested. Fear of arrest keeps sex workers from seeking testing or treatment, which puts their lives at risk and perpetuates the spread of the disease. More specifically, in Uganda, the anti-homosexuality bill, which at the time it was eventually repealed, required healthcare workers to report any men who have sex with men who have accessed healthcare services from them or face imprisonment for failing to do so, with the resultant effect that all men who have sex with men would not access such services for fear of being arrested or prosecuted. Though the bill was eventually repealed, the stigma and fear of healthcare providers remains for those communities. A similar situation occurred in Nigeria after the Same-Sex Marriage Prohibition Act in 2014, where a subsequent study in 2016 found that up to 24% of medical students agreed with the statement that healthcare providers should not provide services to men who have sex with men, and 18.2% agreed that men who have sex with men should not have access to HIV prevention services. Bad policies regarding the LGBTQ plus population don't achieve their problematic goal of eradicating homosexuality. Rather, they further stigmatize these at-risk groups and leave them to die and perpetuate the rest of the epidemic. So not only do sex workers and members of the LGBTQ plus population face prejudice in medical spheres, but health professionals express explicit discomfort or outright refusal to treat these key populations. In Joseph Matovu's qualitative study of health providers in Uganda, homophobia was expressed by the health providers, which presents serious implications for the provision of HIV and other healthcare services to men who have sex with men in Uganda. Over a quarter of health professionals expressed that they would not be comfortable serving men who have sex with men. Though it is likely due to legal barriers and stigmas, it is difficult to quantify because men who have sex with men consistently choose not to identify their sexual orientation. In certain countries, it's largely considered a preference rather than their sexual orientation. Medical professionals often don't even know when they're servicing men who have sex with men. The implications can range from making them uncomfortable to providing them with inadequate care. The same is true for sex workers who are denied treatment or delays to receive services due to their work. This type of mistreatment in the medical community further discourages them from seeking treatment. It should also be noted that legal discrimination and illegality also harm researchers' ability to get accurate statistics on the subject because it's not only taboo, but in many places illegal. As such, much of the research is preliminary and needs to be furthered. In general, African medical professionals have limited skills and information on how to treat sex workers and the LGBTQ plus community correctly. A study in Uganda reported that most healthcare providers accepted that they didn't have the requisite skills necessary to provide HIV services to men who have sex with men and female sex workers. And most of them felt that they needed to be trained in how to handle them, including how to effectively communicate with them. As has been documented elsewhere, lack of cultural and clinical competence by healthcare providers can affect these populations' utilization of HIV and other healthcare services. This lack of specific skills limits their ability to curb the AIDS epidemic, not only because it discourages key populations from seeking treatment, but even when they do, the treatment is usually mediocre, if not worse. All of this assumes, however, that female sex workers and men who have sex with men can access this healthcare. Beyond the fear of health workers, stigma and criminalization contribute to the development of bad policies, like the anti-homosexuality bill in Uganda. For example, Uganda has also sought to pass laws that will make HIV testing compulsory for people arrested on prostitution charges. These violate medical rights by breaching medical confidentiality and mean they can additionally be charged with the felony of intentionally attempting to transmit HIV. Such policies alienate key populations in fighting the epidemic and make it harder to do so. Not only are they discouraged from seeking out testing and treatment, but there are structural barriers to their care. More than half of the men who have sex with men in the Motovu Uganda study reported that they experienced difficulties in accessing HIV services. Furthermore, for female sex workers, fundamental aspects of the operational structure of most healthcare facilities do not cater to female sex workers. Their hours are inconvenient, and they have long wait times. Furthermore, engaging in sex work in the first place is rarely a chosen career path, but a consequence of poverty. Thus, many sex workers do not have the financial capability to receive treatment, even if the cost is low, or even purchase preventative measures like condoms. The stigma against key populations perpetuates their inability to manage their contributions to the epidemic due to inevitable misconceptions and misinformations about sex workers and the LGBTQ plus community. A lack of understanding about the basic aspects of LGBTQ people and sex workers contributes to failures to create policy and treat them. For example, female sex workers are often told to go to health facilities with their male partners for services, like HIV testing and PMTCT services. However, both sex workers and their partners fear identifying themselves as such and will, instead, choose not to go to facilities at all. The practice of instructing them to bring their partners to health clinics highlights a fundamental misunderstanding of how sex workers operate, and it discourages them from getting tested and receiving treatment. The misconceptions of the LGBTQ plus community go beyond just poor treatment and access. In Matovu's study of Ugandan health workers, respondents stated that they would rather discourage men from continuing to have sex with fellow men than treat them for HIV/AIDS. The study further yielded a desire for gender identification training because men who have sex with men adopt a different gender role depending on the day and circumstances. That's a quote from somebody in that study. Both perceptions display a blatant misunderstanding of the LGBTQ plus community and men who have sex with men, highlighting how misinformation can harm treatment procedures. Misperceptions like these can lead men who have sex with men and other members of the LGBTQ plus community to choose not to disclose their sexual orientation, which further diminishes their quality of care. Without understanding both the LGBTQ plus community and sex workers, medical professionals will never be able to treat them effectively and thus will continue to fail to stop the HIV/AIDS epidemic. While the LGBTQ plus community and sex workers face significant barriers to healthcare, limiting the epidemic, and even peaceful existence in African nations, there are also various means for overcoming these challenges. Consolation within their own communities serves as one of the primary forms of reprieve. Those social networks can act as safety nets for key populations in their vulnerable positions as sex workers and members of the LGBTQ plus community. These social groups often encourage the use of preventative measures, testing, and lead them to prevention and treatment programs, while promoting adherence to them, which has been proven to be effective. While members of these communities also stigmatize each other, and they're not a monolith of support, in general, strong social groups have likely been far more effective at limiting the spread of the disease than many government policies. Improvements in the medical field demand three primary changes. One, developing healthcare specific to female sex workers and men who have sex with men. Secondly, sensitizing current clinics and medical professionals. And finally, adjusting legal structures. All participants across different districts voiced a need for establishing specific facilities for sex workers where they can easily access HIV services without fear of being discriminated, embarrassed, or treated in a demeaning way. However, doing so may not be effective because a facility specifically for sex workers would require the same self-identification that is currently a barrier to treatment. While that is a concern, these facilities would still improve the status quo as it would expand access for vulnerable populations. Educating medical professionals on how to treat and communicate with sex workers and members of the LGBTQ plus community would effectively increase their ability to successfully provide treatment, with the added benefit of encouraging people to seek them out. Finally, for any of these actions to be effective in the medical field, legal measures are imperative. African nations must work to create policies that create a favorable environment which male and female sex workers can freely access services without fear of being prosecuted. Such policies should also help to address stigma and discrimination that continue to hamper effective access to and eventual utilization of health services by men who have sex with men and female sex workers. Without adjusting discriminatory laws and legal practices, most other measures will be relatively ineffective at helping key populations and limiting the spread. The stigma associated with sex work and the LGBTQ plus community significantly hinders the ability of African nations to prevent and treat HIV/AIDS. Legal and medical barriers discourage these populations from seeking treatment, and it leads to poor care once they're able to receive it. There are avenues for change in the improvement by resolving the problems within medical structures and tearing down discriminatory policies. However, without significant institutional and social change, the epidemic will continue to ravage many African nations and cost countless lives. So these are the studies and sources I reference, and thanks for watching, and feel free to reach out to me if you have any questions.